Alrighty, so either Robin or Mandy, whoever prefers to present, I will pull up your first case. Are you all able to see that okay?
Yes.
Excellent, thank you.
Hey, boss, I'm gonna let you go ahead if you don't care, because you know how these weenie dogs are. They make a lot of noise.
Okay. Let me try. I'm trying to pull. I can't pull up your other screen. Hang on just one second. I'm having some technical difficulties today. Just give me 1 second.
No worries, take your time.
My problem is I can see all of our faces, but I'm not able to see what you have on the screen. So I'm sorry.
Oh, sometimes the screen, let me stop screen
Let me
share.
exit full screen and see if I can do it that way.
Okay, and then
did-
the re-screen share might pop up for you that way.
Let me put this over on the other side. I'm so sorry. I know that we're holding up everything.
No, that's okay. Sometimes it minimizes to like another little tab, so you might have to kind of look around for it.
I'm so sorry.
That's okay. Let me know if I can help in any way. I'm happy to stop screen share and try it again. It might pop up on your end.
There it went. Now if I can just get back to it. Okay, here we are. I'm ready.
Thank you.
So, okay. Make sure I'm looking at the right one. Yes, I am. Okay, so this is a 36-year-old female patient, a history of IV drug use. The last IV drug use was in 2006. She is currently in one of the rehab programs through Southern Highlands. Smoker. She's claims she's not drinking alcohol at this time. She doesn't have significant comorbidities. Oh, I was trying to stop. I think we did initiate some vitamin D supplementation for her. She's immune to hepatitis A and B. Her labs are not super significant. Her ALT was a tiny bit elevated. Platelets were 395. Kidney function looks good. Her child Turco is she's a class A with a MELD score of 6. Her viral load 122,000 with genotype 1A. And I feel like with this particular patient, she's excited about being treated, so I think she'll do well. I hope she wouldn't be one to relapse, but I feel like Maverick's going to be a good option for her. So, is there anything else you want me to add? I feel like I rushed through that one.
No, not at all. That was a great case presentation, went through everything. So anyone with any clarifying questions for Robin about that case, feel free to unmute or chat in.
Hey, Robin, it's Kaylee. A couple clarifying questions. On her comorbidities, it said Hep B, and then, but it looked like then it says she's immune. Can you clarify?
I think she was, her core might have been positive. Let me pull her back up.
Okay.
I think if I were, hang on, before I even start talking, let me just pull her up so I'm not making up stuff. All right. So her Hep B core was positive, but I think her antibodies, surface antibodies were reactive. So she is immune to
Okay, gotcha. So it's natural history, but immunity. Okay, I just wanted to clarify that. So not at risk for reactivation. What about her, is she on any kind of contraception?
Let me look at her medication. She is not currently, I think she had a tubal, but let me double check that too. I'm sorry. Mandy does most of my footwork on this, so.
Oh, it's fine. It's fine. I just wanted to clarify. I mean, Maverick would be, for 8 would be great for her as long as she's not on any kind of ethanol estradiol containing contraceptive methods, and we just need to avoid pregnancy and get a pregnancy screen before she starts treatment, unless she's had any.
I don't, I'll have to find that out. Usually what I try to do is if they're not on anything and they say they are sexually active, I'll go ahead and put them on just like Myprenor or progestin on the birth control.
Gotcha. Perfect. Okay. Yeah.
I'll have to touch base with her because I really, there's so many of them. I'll touch base with her before we get started on it.
Yeah. I agree totally.
Hey guys,
Maverick,
she's
though.
currently not on anything. She's relatively new to us.
Okay.
So we're gonna have to definitely start her on something and get her screened before we can actually treat her.
Gotcha. Okay. And honestly, I mean, if she's active and willing to use condoms and as opposed to doing any kind of other contraception, I think that's her choice too. But I mean, if she Maverick would be fine as long as she doesn't start on any kind of ethanol estradiol and pregnancy status remains negative. But yeah, I agree with that regimen. Thank you so much.
So when you said, should I get a pregnancy test on every single person before they start? Is that what I should be doing?
And not on every, I'd say if they're what'd you say?
If they're a woman.
John says if they're a woman. No, if they're a childbearing age and unless there's truly no chance at all of pregnancy, I usually just snag one because that's my comfort. But if she's of childbearing age and hasn't had a hysterectomy or tubal, or even if she hasn't been recently sexually active, I still just kind of like to have one and know their last menses as well. But and then just counsel about avoiding pregnancy on treatment.
Okay, sure, I'll do that.
Yeah, thanks so much.
Thank you all so much. Any other feedback or recommendations about this case?
Hey, I just pulled her stuff up. I should have included that. She's had publications, so that's why we weren't concerned that much with the birth control point of view.
Awesome. Thanks so much.
Thank you, both Amanda and Robin. And Robin, were there any other questions or things you wanted addressed about this case?
I think she's one of the easier ones for us. So.
Awesome. No, that's great to hear. Thank you so much. All right, let me go ahead and pull up your second case. All righty. Are you able to see that okay, Robin?
I am. Mm-hmm.
Excellent.
Okay, so this is a 32-year-old male. Very excited about his treatment. He actually came in yesterday wanting to know what was going on with him. So I think he is going to do very well. IV drug use for 10 years, been clean for 2 years, except he had one recent relapse, but he's clean now for 6 months, probably a little bit more now since we submitted this. He is in a substance abuse program. He has a job, he's stable now, he's a smoker. I feel like he has a good family support system, so I think he's got good backup to help him stay clean through this process. He is on a vitamin D supplementation. I don't see any contraindications as far as his medications to treatment. He is willing to both have vitamin and B. Labs, his liver enzymes were quite a bit elevated. Platelets were okay. Kidney function was okay. He is a child Turco-Q class A with a MELD score of 6 and a viral load of looks like 5,590,000. He doesn't have fibrosis, so he was at F0. His AFP was good, 1.9, and he was genotype 3. So again, Maverick is what I'm going to recommend for him.
Excellent. Thank you again, Robin. Any clarifying questions about this one?
Hey, Robin, it's Kaylee again. A couple questions I just had with him. Do you have any liver imaging on him? Sound or anything?
No, not yet on him. Let me see.
I would recommend that with him. You know, he's likely had Hep C or potentially could have had it for several years or for over a decade. And then he's genotype 3, even though his fibro test is reassuring, his APRI is elevated. That's more concerning for advanced fibrosis, and his liver enzymes are pretty significantly elevated. So I would go ahead and snag a right upper quadrant on him, just to ensure that there's no liver cirrhosis. And I would agree with you. You know, you could go ahead and treat him with Mavorite. Remember, with our other pangenotypic Epclusa, if this patient were cirrhotic, being that he's genotype 3, you'd want to get baseline NS5A testing. So just for kind of less complexity, Mavorite would be preferential with this patient. And then the other thing I was going to ask too was about his Hep B status as well. It's probably the same thing as the last patient, but it had Hep B listed as comorbidities, and then his immune status said yes to Hep B. So is he also a core?
Yes, his core was positive.
And is his surface antibody positive as well?
Yes, he was reactive.
Okay, I just wanted to clarify. All right, thank you so much.
Thanks, Kaylee. Any other feedback from the group or recommendations? And Robin, anything else you wanted to go over about this case before we go to the next one?
I don't think so, not on that one.
All right, excellent. Thank you so much. Let me pull up your third one there. All righty, I'll turn it to you.
This is a 44-year-old female. I think she had a significant history of abuse when she was younger, which is, you know, she had some issues with Hep B exposure, I think, in the past. She's been cleaned for 3 years from IV drug use, but she did have a significant history with IV drug use for many years. She has tried several different rehab programs. She's currently in a program and seems to be doing well. She's had a few tattoos that she got while she was incarcerated. She has several comorbidities, a lot of mental health issues. A lot of that stems from her abuse as a child. I was trying to scroll. Her medications, I don't think that there's anything significant about her medicine that I needed to worry about. Okay, so she was immune to Hep B. She was core positive and non-reactive. So, and I know there was some controversy at some point about whether or not we should vaccinate if they're core positive and they're non-reactive. So if y'all want to touch on that again, I'd be glad to listen to that again. But going over her labs quickly, she's a class A on the child Turco-Q. She has, her liver enzymes are a little elevated, but not terribly. I've seen much worse. A MELD score of 7 with her. I did check the hepatitis B viral load, and she had no hepatitis B detected. So I kind of wanted to know, I know that when we start treating, that can reactivate hepatitis B. So if there is no viral load, is there a possibility that treating her is going to cause that to activate and it might start reproducing?
Thank you so much, Robin. All right, I know there were a few things you had asked throughout that case, but before we jump into that, any clarifying questions?
Imaging as well, or not? We just
Yeah, I think, Robin, my only clarifying question with her was about contraception again. Do you know her pregnancy status?
well, I know she's not pregnant. She's in the rehab program over here, but I can't
No.
remember if she had a tubal or not. I'll have to look. I honestly, really have a lot, and they run together, so I'll have to double check
Yeah.
about that.
Okay.
Seems like
She's
she had a
actually, she's been in our Suboxone program at Tug River for several years, before she went in inpatient up there. And she hasn't had a positive pregnancy test in any of that time.
Okay.
She's got had an ablation done several years ago and hasn't really had any menstrual cycle since then.
Gotcha.
And we did start Hep B vaccines because she wasn't immune. She's already had 2 of the 3-part series.
Okay. And yeah, you could always repeat a titer and just see Hep B surface antibody and just see if she's had any response. I mean, she's had prior Hep B exposure. It appears this is inactive. I would tell you that her risk of reactivation is very low. So 2% could happen, likely not. In terms of monitoring while she's on treatment, really, as long as I'd say, you know, I know you checked her DNA, but you could monitor her liver enzymes and surface antigen
Okay.
during and then even after treatment. So I'd still continue to follow it after treatment as well, because there is that risk of reactivation post treatment, at least in the short post treatment period. But I wouldn't.
Quarterly, I'm sorry.
What'd you say?
You think quarterly for a year would be adequate, or do you think like long
You know what,
term?
even less, yeah, no, even less than that. So I would check liver enzymes and surface antigen at 1 month, at her 1 month, 1 month into treatment.
Okay.
If there's no transaminitis at that point, or her transaminitis has resolved,
Okay.
I would consider checking it again, just hepatic panel and then surface antigen end of treatment. And then if everything still looks good, then I just check it SVR12.
Okay.
Unless, you know, and certainly counsel her on, again, it's very, very low risk. If she's only isolated core positive, since you've already started the vaccine series, hopefully that will kind of boost her immune response. But I think it's worthwhile to just kind of keep an eye on it. But I'd still counsel her just on signs to watch for signs of clinical hepatitis. If she's concerned about any of those developing, then to notify you, and you can spot check surface antigen and hepatic panel.
Okay. All right.
And this is John. I'm thankful that Kaylee knows those numbers, like how low the risk it is. It's very comforting. Further comfort, you know, when Hep B reactivates and does cause trouble, it's usually in people that it's where it actually hurts you. It's in the setting of if you already are a cirrhotic and sort of having borderline homeostasis, where reactivation will really, you know, tip you over the edge. And fortunately, I don't think we're there on this one. Do you think we should image this one?
Not yet.
No.
We don't have any. We can, when they're in the programs over here, they kind of frown upon me sending them to a whole lot of appointments, because then they miss their
Sure.
rehab meetings. And so I kind of put that off until they have their passes. They get some passes where they can leave for 4 hours at a time. So we try to kind of wait till they get to their passes before we start scheduling for outpatient, you know, imaging.
Gotcha.
But-
And I wouldn't say that should necessarily delay treatment if she's really engaged, but her APRI was also elevated. And she's also a genotype 3 with not as high transaminitis as the last patient you presented, but still there. So I would certainly still want to snag a right upper quadrant on her at some point as well, but shouldn't precede her treatment if she's ready to get this started.
Okay.
The last comment I wanted to make on her was, you know, I always peruse the past medical history for any sign of extrahepatic manifestations. And there was a couple things. She got the thyroid disease, which you can't ever assign causality, but, you know, remember thyroid disease and Hep C run together so much in a autoimmune mechanism. And then I saw joint pains and, you know, arthritis-y stuff. So maybe we'll make her feel better and stuff like that. So always optimistic on that end. I don't know if she got a rheumatoid factor screen or anything like that, but remember those can be false positive in our Hep C patients. So
Okay, you probably mentioned that before, but I had, today that's new to me.
Okay, yeah, it's mild. It's part of the whole chronic inflammatory response of a chronic viral illness like Hep C, and you can induce autoantibodies, and one of those autoantibodies is can be rheumatoid factor, and it can confuse the picture in the setting of chronic joint pain. So you can accidentally label somebody with rheumatoid arthritis when in fact they just simply have Hep C and arthritis. So
Well, you know what? Now that you said that, I've got another patient that she had positive rheumatoid labs, and I probably need to reevaluate that too. So I'm glad you brought that up again today.
yeah. So check a CCP in that other patient and see if that's positive or negative.
Okay. All right. So I'll take a CCP. All right. All right. Well, I appreciate you guys. And so Maverick was that's the best option for her too, is what I'm saying.
Yes,
Maverick and everybody.
agree with Maverick for 8. I don't have any more comments about these cases in particular, but I wanted to mention, something that I think we kind of just assume when we're presenting these cases, but we may want to update the form as well, is about prior treatment history. I think we kind of just assume treatment naive unless specified otherwise, but as we're having increased access to treatment with these direct acting antivirals, I think it's important that we make sure we're clarifying with patients any kind of prior treatment too. So we might want to add that as a specific line on the form also.
Yeah, that's a good point, Kaylee. I'll make note of that and then notify our group for that update. Thank you. No, thank you, Kaylee and John, for those recommendations. Any other comments about any of the 3 cases that were presented from anyone? And any other questions, Robin or Amanda, about your cases?
I think so.
All right.
Nope,
Well,
I really appreciate you guys.
well, we appreciate you both as well. Thank you both so much for bringing these cases today. All righty, Angie, I will turn things over to you now. I gave you the screen share abilities, so anytime you're ready, I'll just turn it over to you.
All righty, let me share my screen. You guys see my screen?
Yes, ma'am.
Awesome. All right. So today we'll talk about HIV drug interactions. And before I go into this, this is a presentation I'm actually giving next week for Dr. Feinberg's HIV AMP group. So if anyone is interested in that organization, I know everybody's probably pretty familiar with Dr. Feinberg, reach out to her because it's a great program. What it is a telementoring program to help physicians prescribe and monitor patients who have HIV in the state, since, as you know, it's becoming more and more of a problem in our state, unfortunately. But if anybody wants additional info on that or Dr. Feinberg's contact information, just let me know and we can get you hooked up with that.
And Angie, I'm sorry to interrupt you. It's still not in the presentation mode. So if you go down to the
Oh, yeah, you're right. Thank you.
There we go. And then you can always send me any information you want shown in the recap email as well.
Yeah, let me switch my screen here because I've got it on the wrong one. There we go. You guys got the right view now, right?
That looks perfect. Yes, thank you.
Awesome. Thank you. Okay, so to back up, we'll talk about the types of drug-drug interactions. So you have pharmacodynamic and pharmacokinetic drug-drug interactions. So pharmacodynamic drug-drug interactions are where one drug is going to work at the same receptor site as another drug, and it's going to cause either a competing or an additive effect. For pharmacokinetic drug-drug interactions, this is going to be where one drug changes the level of metabolism, absorption, or excretion of another drug. So pharmacokinetic drug-drug interactions usually involve one of the 2 enzymatic pathways. So either cytochrome P450 enzyme pathway or the phase 2 conjugation pathway. Phase 2 conjugation pathways, for example, will pair a drug or metabolite with another molecule, sometimes something that might make it, for example, more water soluble, and therefore it will be excreted more quickly or readily as opposed to staying in the body longer and accumulating. So these two enzymatic pathways metabolize some of the medications, and other medications can affect the rate of that metabolism by either inducing or inhibiting these enzymes. So if drug A inhibits this pathway, they might make drug B accumulate longer in the body. On the flip side, if drug A induces one of these pathways, they might make drug B, which is metabolized by this pathway, be excreted faster. And something to note if you're counseling a patient or noticing that a patient has had a drug-drug interaction is that if the interaction is rooted in the drug metabolism being induced, it can take a couple of days or weeks to see that change take effect. So if you notice they're having a drug-drug interaction and you stop whichever drug you want to stop, and you notice it doesn't correct the problem right away and it takes a little bit of time to see that, or if you see the problem creep on a couple of weeks after the second drug is being started, and if the mechanism is that it's being an inducer, then that can be a reason. So that's something to keep kind of in the back of your mind. On the flip side of that, if it's due to inhibition, that tends to take place more immediately, more readily. So that can be something that happens quicker. And then we'll touch on transmembrane proteins as well, because they can be affected also, and they regulate molecules being transported across epithelial membranes. So we see that happening in, for example, the intestine, the liver, the kidney, and the blood-brain barrier. So cytochrome P450 metabolizes about 50% of all medications. So that's a lot. And we see these drug interactions all the time. And if you ask any pharmacy major, knowing these pathways is super tough and what we always dread taking our boards. But for purposes today, I won't stress which CYP pathway is affected. The important thing to note as a prescriber or as a clinician is just to know that there is an interaction when there's a significant interaction. Some common examples of these enzymatic pathways are listed there, the different CYP pathways, and transmembrane proteins are listed there for your information as well. The UGT enzyme pathway that's listed on there as the phase 2 conjugation pathway, that is the metabolizer of one of our newer medications that's commonly used, raltegravir. Sorry. Because it uses this pathway for metabolism. It isn't subject to some of the more common drug-drug interactions that plague some of the older HIV medication treatment options. So sometimes getting away from the CYP enzymatic pathway is beneficial. So now I'll talk more specifically about some common drug-drug interactions that can occur with our most commonly used class of medications, which is the integrase strand inhibitor class. So these medications work by exerting an effect on the integrase protein, and therefore they make it able to keep the HIV virus from integrating itself, its genetic code, into the host or human cells. So it's important to remember when we're thinking about treating patients that we want to treat the patient as a whole. And so we can't exist in our silo looking only at the infectious disease component of their health. We want to look at, what their lifestyle choices are, their other disease states that are both in existence and then being treated by medications that can interact with medications that treat the HIV for the patient. So we have to take all of those things into consideration. So integrase strand transfer inhibitors do have few drug interactions, so that's pretty great. So they're a great class to use because some of the older classes like protease inhibitors, they had lots and lots of drug interactions. So this is a great thing as they're kind of the mainstay of modern therapy for HIV. They're efficacious and they have few drug-drug interactions and they have fewer side effects. So that's a great option for patients. The primary concern with this class of medication is going to be cations, so things that are in antacid therapy. For instance, magnesium, calcium, and aluminum. That's what we want to watch out for drug interactions with this class. And it's good to note, though, that it's not affected by other therapies that you use to suppress gastric acid. So, for example, your H2 receptor antagonists, so very commonly used things that are also over the counter like Pepcid, famotidine, your proton pump inhibitors like your Prilosec, Nexium, things like that. So those would not be affected with this class of medication. So we're just looking at antacids interacting. So they don't seem to have significant drug interactions with most illicit drugs. They don't really interact with substance use disorder drugs. They don't have huge interactions with birth controls, more modernly used mental health medications. I put that caveat in there because, you know, things like St. John's wort, they do interact with some of these medications, MAOIs, things like that. But I don't think a lot of practitioners are really using things like that. And I don't think a lot of people still use St. John's wort. So I didn't really go too in depth into those interactions. But for things that are used as like mainstay treatment guideline therapies for those disease states, you generally get to avoid the drug interactions. Benzodiazepine statins for treatment of cholesterol, other commonly used medications you don't have to worry too much about. So those interactions can be a concern for older HIV patients, and they are definitely a concern for the older HIV medications as well. So it's really great now that our HIV patients are living same life expectancy as non-HIV patients, and so they're aging into some of these disease states that we don't have those concerns that we used to have probably 2 decades ago. So we do have to point out an exception. So the integrase strand transfer inhibitor class does contain a medication called elbapatagravir. Now, this one does have some drug interactions, but the thing with this one is that it's not in one of the most commonly recommended regimens. So the guidelines for treatment of HIV, they have recommendations on like 5 most common groups of medications to treat some treatment regimens for patients who are treatment naive. This is not going to be included in that. So when I say that you get out of the drug interactions for most disease states, I'm talking with the exception of this medication. And the reason that this medication is kind of the problem child is because it has to be boosted by covisistat. So it has to be boosted in order to maintain adequate plasma levels. So in order to be efficacious, you have to boost it, and the booster causes so many drug interactions. So that's why it's a little bit more problematic, and it interacts with drugs of abuse, so like heroin, fentanyl, cocaine, including things that are used for opioid use disorder or withdrawal. So buprenorphine, which is in our common ingredient in Suboxone. Contraceptives can be problematic, sedative hypnotics. So it can cause some problems, have some significant drug interactions. So luckily, it's the only medication in this class that we really have to worry about. And it's really not one of the recommended therapies. Now, that being said, if you have a patient that has been on therapy and is not treatment naive, this medication, elbapatagravir, is in some of the commonly used combination products like Stribild or Genvoya. So it's something to take into consideration. So now we'll look more specifically at the acid reducers and this class of medications. So as you can see, we've got some things to keep in mind and look out for. And it's nice, our 2 rows at the bottom, that we don't have to worry about the H2 receptor antagonists or the proton pump inhibitors. But if we look at the antacids, we have to be careful with almost all of our integrase strand transfer inhibitors. The one exception is our cabotegravir, which is our IM injection. It doesn't seem to interact with antacids, which is a good thing. But for others, you have to be careful of these interactions. And this class interacts with these medications because the antacids bind to the integrase strand transfer inhibitor in the gut, and it tends to prevent their absorption. So we don't want to do anything that's going to inhibit the efficacy of our HIV medication, certainly. So it's a concern. So for the most part, though, the good news is you can just separate the administration. So you just have to counsel the patients, and it's good to counsel them even if you don't know that they're on antacids, because sometimes people don't take them regularly, only take them when they eat a spicy meal or whatever it might be. So it's good to give them a heads up on this interaction and just have them separate the administration accordingly so you can kind of mitigate this issue. So for raltegravir, you have your aluminum and magnesium antacids, so like your Maalox, your Gaviscon acid gone. For that, you really don't want to co-administer, but you can co-administer ones that have calcium carbonate, so like Tums, Alka-Seltzer, Rolaids. is okay if you use the twice daily raltegravir. Now, you wouldn't need to separate or do dosage adjustment, but if you're doing the once daily raltegravir, you do have to not co-administer. So that's where the concern kind of lies. And of course, we're always going for the fewest administration daily. So a lot of patients are on the once daily. So that's a concern for that. For bictegravir, you want to avoid co-administration with an antacid containing calcium on an empty stomach. And some of these guidelines vary depending upon the source that you look at as to how many hours of separation that it requires. So just kind of look at the sources. This is what's recommended in most of the American guidelines. So that's what's reflective on my slide. Here are some drug-drug interaction resources for your, in case you ever need it for any other medications, in case you're prescribing something that maybe isn't for a treatment-naive patient or isn't first line. And that's where HIV AMP is super resourceful too, because they will help with some of those more difficult to treat patients. They can offer some mentoring for that purpose. But the Liverpool HIV guidelines, drug interaction guidelines are a really good resource. You can kind of plug and chug your 2 medications in and it'll tell you the interaction or the likelihood of interaction, because a lot of drug interactions with HIV are things that we're basing on science. So we're assuming, you know, if you take X medication with methamphetamine, that it's probably going to interact based on, you know, the pathway that it takes. But of course, for, you know, ethical reasons, that's not really well studied. So the Liverpool HIV Drug Interaction website can help really well with that. And then the clinical info guidelines, they're not really something you can enter a medication name in, but they sort of list the interactions going down the page. And then of course, the other websites are on there as well. Does anybody have any questions?
Thank you so much, Angie. What a great rundown of all those drug interactions. Oh, I don't know why my video is glitching. It's not starting for some reason. There we go. Thank you so much. Any questions for Angie or comments?
Angie, I don't have any questions. This is Jennifer Boyd, but I just appreciate that you make this kind of stuff digestible. It can be it can feel like a quagmire to me, and your presentations are always clear. And
Oh, thank you. I appreciate that feedback.
yeah, mhm.
Any other comments? It's a quiet group today. But I agree with Jen as well. I'm not a clinician, but I can totally see how you make that so much easier to understand, especially for such a complex topic. We appreciate it.
Thank you.
Right. There's nothing else. We did get some information shared by the CDC. Let me see if I might just screen share it instead of reading out loud to you all. Let me see, and I'll add this to the recap email as well. But Jay was given some of this information he wanted me to share with you all. Might just be something that is helpful for you all to know. And again, I'll include this in the recap email, so you'll have the emails and all of those things as well. Any questions on this? You can always email me as well if you sort of digest it and have questions later on. Alrighty. Well, thank you all again so much for joining. Thank you to both our case presenters. Thank you to our hub members for helping with the recommendations as always. And thank you, Angie, for the great presentation. We appreciate you all very much. My only announcement is that the next time we'll meet is on May 25th, and we'll do a session of all cases, which is always fun. Thank you all so much, and we'll see you next time. Take care.